All right. Thank you, Dr. Stiff and Linda and everyone at the Leukemia Research Foundation for allowing me to present today. So I've been given the somewhat daunting task of condensing in 20 minutes how we use the plethora really of molecular information we now have to really translate to real-time changes in the clinic. And so I'm really just going to focus on very actionable results that we get when we do molecular profiling of hematologic malignancies. All right. So when we think about molecular profiling, and really when I speak about molecular profiling, I'm talking about taking tumor cells and sequencing them in a targeted way for mutations that we know are relevant to prognosis and treatment, and trying to discern multiple subsets, as Dr. Stiff earlier explained. So when we think of the molecular profile as kind of a prism, we're taking the beam of what we used to perceive as one homogeneous malignancy, for example, leukemia, and really breaking it down to its molecular subsets. And that's really very relevant to how we're going to move forward in terms of clinical trial development, because the norm of clinical trial and testing of new drugs has been to apply a novel therapy to existing therapy. And when we apply that to the beam of white light here, there may be a subset of patients that are benefiting, but due to the signal-to-noise ratio, we're losing those. And when we then tease out the molecular subsets into their fractions and then target a treatment to the subset that's most likely to benefit, then we actually get positive results from trials and can move the field forward. So the way I plan to break up this talk is to outline first and foremost, I think, the most relevant issue that molecular typing allows us to identify druggable targets. And that is, of course, very immediately actionable. But in addition to a mutation that provides a target, there are mutations that we know are not directly targetable, but predict sensitivity to certain therapies. And therefore, we can pick a treatment modality based on the molecular profile. Then in addition, there are certain diseases where we have a range of therapeutic options ranging from observation to something as aggressive as a stem cell transplant. And whereas previously we used clinical markers to determine how to manage these patients, now the molecular profile is factoring into the traditional clinical pathologic classification systems and better informing the prognostic decision-making and management. And then finally, I'd like to touch very briefly on familial syndromes, and this is an area that's really garnering a lot of interest and enthusiasm, as we recognize that patients that have certain molecular abnormalities may actually have an underlying germline condition, and this has actually been included in the WHO 2016 revision to how we diagnose blood cancers and classify them. And that is myeloid neoplasms with a germline mutation, and that means a mutation you are born with and is present in all of your cells. And this becomes relevant because when we find the mutation in your leukemia, we may need to look back and see if it's present in your germline, and the relevance of that would be, number one, to the patient, that there are other malignancies that they would therefore be at risk of, but in addition also to their family members in terms of screening and relevance to their clinical care. And then finally, just to be the devil's advocate, I'm going to touch on the downside to all of this testing and some of the conundrums that we as clinicians and you as patients face when we get back a test that we don't know exactly what to do with. So I'm going to try and use cases to kind of illustrate some of these points. And I'll start with a 70-year-old cat lover. So this is a patient of mine who was 73 years old when she presented to us. She had a known history of a chronic autoimmune disease called sarcoidosis, coronary artery disease, so a number of comorbid conditions, and was diagnosed with acute myeloid leukemia, but based on her cytogenetic profile, which is the analysis of the chromosomes in her leukemia cells, she was classified as favorable risk disease, which means that she's quite likely to respond well to chemotherapy and perhaps may not need something as aggressive as a stem cell transplant, which would already be somewhat difficult undertaking with her comorbidities. So we went ahead and treated her with conventional chemotherapy for acute myeloid leukemia, which is 2 drugs. And she did achieve a remission. However, given her comorbidities, she did have some complications along the way related to heart rhythm problems, etc. And her hospitalization was around 6 weeks long. She was a little deconditioned by the end of it. So it was a long road, but she got there. So she went back to life, was back home with her 20 cats, doing the things she enjoyed doing. And then a year later, the blood count started changing and she was relapsing. And so, she has had a rocky course before, and she's very clear about the fact that she wants her independence and wants to maintain her quality of life and try and be at home as much as she can. So, as we do now, pretty much with everybody, her leukemia cells were sequenced, and she tested positive for a pathogenic mutation in a gene known as IDH2. So what is IDH? IDH is an enzyme. It's an acronym for isocitrate dehydrogenase. So this is a cartoon that you definitely don't need to know much about, except that this is a cell, this is the nucleus, and this is the mitochondria. The mitochondria is basically the factory where energy sources like carbohydrates are converted to actual energy molecules like ATP. And in order to do that, there's a number of oxidation reduction reactions that happen. And one of the enzymes involved in this is isocitrate dehydrogenase. And IDH1 is the enzyme when it's found in the cytoplasm, and IDH2 is in the mitochondria. So as a result of the mutation that was identified back in 2009 in acute myeloid leukemia, isocitrate dehydrogenase, which normally results in this metabolite called alpha-ketoglutarate, undergoes an additional step and becomes what we call an oncometabolite. So normally alpha-ketoglutarate goes through a different pathway, it becomes something else, but because this enzyme is mutated, it converts it to a new product. So that's called a neomorphic enzyme. It's an enzyme with a new function that shouldn't be there if you had the wild type enzyme. So this is important because, number one, it becomes a biomarker, because you shouldn't have 2-hydroxyglutarate at detectable levels in the serum of normal patients or IDH unmutated patients, whereas it's elevated when you have this mutation. So in addition to providing us with a biomarker that we can follow for diagnosis, we can also follow it for potentially testing the efficacy of treatments. IDH1 and 2 inhibitors quickly started developing. And the results of both IDH1 and IDH2 inhibitors have been presented at the National Hematology Conference. And in 2015, the results were presented, an oral abstract. And this is a study of patients who had relapsed acute myeloid and MDS, so 2 myeloid malignancies where IDH2 mutations are found. And just to kind of backtrack, about 10 to 15% of patients have IDH1, and the similar percentage have IDH2 mutations. So they're not very rare. The response rates remain pretty impressive. This is kind of a waterfall plot. And it basically is showing, the different colors are showing different degrees of response. And the length of the line indicates how long patients are on treatment in months. And the longest is beyond 14 months. So about 40% of patients had a response, which means a reduction in leukemia. An additional 30% had stable disease, which means at least the progression was halted. So that's pretty impressive results for a drug in early phase testing. And that's why now there's a phase 3 trial where it is being compared to physician's choice in patients who have the IDH2 mutation. There's also an IDH1 inhibitor that is in trials. So going back to our patient, she was enrolled in this trial and fortunately randomized to the drug, which she is getting her first cycle of. So that brings me to another mutation that's going to be, I'm sure, the topic of a lot of discussion today, and that's FLT3 mutant AML. So the FLT3 is a mutation that's found in about 30% of leukemia cases. This is, FLT3 is a cytokine, which is sort of a locally acting hormone, and it's present in the bone marrow, and its job is to make bone marrow progenitor cells divide. So it's present normally, it stimulates the precursor cells in the bone marrow to divide, and also stimulates leukemia cells to divide. So this mutation found in 30% of leukemia patients causes their leukemia cells to divide faster, and generally patients that have this are at risk of relapse. So we had a patient who was 54 years old when she presented with a FLT3 internal tandem duplication. That's the kind of mutation that's found most commonly. And she received standard induction chemotherapy, and knowing that she was at high risk of relapse, was quickly triaged to a bone marrow transplant. However, within 12 months following her transplant, her disease did relapse. And the question is now, what do we do? So the FLT3 mutation was actually identified back in 1999 by a Japanese group. So this has had a head start on the IDH inhibitors, and FLT3 inhibitors have been in development for a long time. Starting with the more broad inhibitors, which inhibit multiple kinases. Kinases are enzymes that activate downstream targets. And just to give you an idea, this is called a kinome map, and what it is show every red circle is indicating a kinase pathway that is inhibited. So just to show you that the older inhibitors, like lusteritinib, Midasoran, these are pretty non-specific. They're hitting multiple kinases, and that has been one of the challenges with FLT3 inhibitors, that they've been pretty non-specific. They've really been developed as other inhibitors and have been found to, oh, by the way, inhibit FLT3. So now the direction has really been to develop second generation and more advanced molecules to inhibit FLT3 that are really very focused, and this is one of the ones that's a little bit further in development, called quizartinib, AC220, and as you can see, there's only a few red dots there indicating a more focused spectrum of activity. And so the one that you're going to hear a lot about today is the one that Dr. Stiff alluded to, which is Midasoran, and this is one of the earlier, more non-specific inhibitors of FLT3 that was used, but this has been clinically approved for FLT3 mutated AML. And that is based on a recent clinical trial called the Ratified trial that was presented at the American Society of Hematology meeting in 2015. The drug, however, just approved last month. And this basically added midostaurin up front, so not in the relapse setting, but right at diagnosis in patients younger than 60 in combination with chemotherapy. And it was really continued right through chemotherapy, consolidation, and for 12 months post-treatment. Completion and compared in a randomized manner to standard therapy, which is basically everything without the drug, without the midostaurin. And they were able to show a very hard endpoint of improved survival, which is kind of a difficult goal to meet, especially because a number of these patients along the way do go to transplant, and a number did in both arms, and the benefit persisted. So midostaurin is now FDA approved for patients under 60 in combination with chemotherapy. The relevance, so going back to our patient, in her case, she, at that point in time, we do not have access to midostaurin. We do not have this data, which is why she did not get it. But at the time of relapse, she was initiated on one of the other FLT3 inhibitors I showed you, which is called sorafenib, which is actually off-label use of the drug. It's FDA approved for liver cancer, but it does inhibit FLT3 and has shown activity. And so frequently, we, in the absence of an approved agent, people use that to inhibit FLT3. And it did, within a few cycles, put her back into remission. So now my third case has a couple of points tied into it. So this is the case of a 35-year-old lady who was transferred to us with a newly diagnosed acute myeloid leukemia. Interestingly, her history revealed prior breast cancer that was treated with chemotherapy and radiation, and then a breast sarcoma that developed after that, for which she needed to have a mastectomy. So when the sequencing of her AML was done, it showed a loss of function mutation in P53. P53 is the most commonly mutated gene across all cancers. It's mutated in about somewhere around 15% of cases of AML. And if we take all comers of AML, but if you take AML chromosomal abnormalities, they're very enriched in P53 mutations. And the reason is that the P53 mutation is a gatekeeper gene. So it's the gene that tells your cells they have to die when they've been injured. And if it loses its function, then a cell can accumulate multiple insults and continue to expand. And that's what happens when you have a small P53 mutant clone at diagnosis and you treat a patient with chemotherapy. That P53 clone hangs in there because it's the one that's not going to let the cells die, and eventually acquires additional hits that make a P53 mutant disease. So So traditional chemotherapy, which is cytotoxic, is probably not the best approach in a cell that doesn't know that it's supposed to die after it gets injured. And so alternative approaches have been used in this group of diseases. And decitabine, which is a hypomethylator, acts in a slightly different way than cytotoxic chemotherapy in that it changes the methylation profile and the way genes are expressed in a leukemia. And in an animal model, which is a patient-derived AML put into an animal, when this is placebo, this is cytarabine, which is the backbone of AML chemotherapy, and this is decitabine. Decitabine showed much more activity. The red areas are the tumor, so you can see it's really responded a lot better than cytarabine, which looks very much like placebo. So a clinical trial was undertaken. This is a single-arm trial at Washington University and the University of Chicago, 120-ish patients, and they were treated with decitabine to try and tease out which patients benefit from decitabine. And this decitabine alone, it is given for 10 days in a row, a little bit different than we traditionally use it for 5 days. And they saw that 100% of the patients with the P53 mutation, which are the green boxes, responded to the drug. These are the non-responders, these are the responders. And so this kind of activity in P53 mutant leukemia has never been seen before, and that earned a New England Journal publication. Also this was very tightly correlated. The blue dots here are patients that have complex chromosomal abnormalities. So when their cells are looked at under the microscope and the chromosomes are evaluated for additions and losses, they're usually pretty complex. Again, just supporting the fact that these are unstable genomes. And so when they tried to sequence what does the decitabine do to the P53, you can see that the level of the mutation, which is called the allele burden, actually came down in all of them, which means it really was targeting the P53 mutant clone, and that does take a few cycles to actually see the clone come down. Going back to our patient, she did have resistant disease to her first 2 cycles of chemotherapy that she received elsewhere. Then she was put on decitabine and eventually taken to transplant and is a little over a year out from transplant. I will state that even on this clinical trial, although decitabine had responses, they are not permanent responses. They last up several months, but the patients that really benefit in terms of survival are the ones who do go to transplant. So it is still a bridge to transplant. And then just touching on one other aspect of this patient's history, because there's a syndrome known as Leukemia syndrome where you have germline mutations in P53, which is mutations you're born with. There are several malignancies that you're predisposed to, which include breast cancer and sarcoma. This is just an example of a family tree of somebody with Leukemia syndrome, and it's a little bit concerning that our patient had 3 of the malignancies associated, the sarcoma, the breast cancer, and the leukemia. And so we then tested her skin biopsy to see that is this a mutation that's all over her body or is it just in the leukemia? And she did in fact have a germline mutation, and now her siblings and children are being screened, and she is being monitored by our genetics team. So I'm just going to shift gears very briefly and talk about lymphoid malignancies. So I think the one paper that has generated a lot of interest is the fact that previously our approach to ALL was pretty binary, that you either have the Philadelphia chromosome or you don't. And that's because we had a way to target the Philadelphia-like ALL using the same kind of treatments we use in CML, because that's the same chromosomal rearrangement. But their gene expression profiling show that there's actually a subset of the Philadelphia negative ALLs that behave very much, and they look, in terms of the targets that are activated in these patients, are very much like the Philadelphia, like the Philadelphia positive ALL. And so the group at St. Jude's took on a very major task of about 1,700 Philadelphia negative ALL patients who they did gene expression profiling and figured out who has a profile similar to Philadelphia positive patients, which tend to be a little bit more aggressive. And then let's work backward and see what's driving their disease, because the end result is the same as the Philadelphia positive ALL, but the driver is different. And so they analyzed their chromosomes for rearrangements, and they found that there are multiple drivers in the Philadelphia negative subset of ALL, some of which you may have heard of, the JAK2 mutation. And then while the Philadelphia positive ALL is driven by a kinase called Abl kinase, because it's rearranged with BCR, there are other partners that could be rearranged with that we were missing. So they found other fusion partners that activated Abl. And now you can actually test for those with FISH assays, and they tested the cells of these patients with these Philadelphia-like chromosomes with different pathways activated with inhibitors against them, like JAK inhibitors, dasatinib, and found that they were able to achieve responses. And that's important because this subset of patients does really poorly, and about 30% of young adults have Philadelphia-like ALL with very poor survival. So now the consortium and cooperative group trials are devising clinical trials for Philadelphia-like disease where everybody's going to be tested up front to try and find these mutations that and add in the inhibitor that will try and improve the outcomes when added into chemotherapy. And then just to touch on another lymphoid malignancy, and this is now speaking more to the fact that certain mutations tell us that certain patients may benefit from therapies which may not directly inhibit the mutation but are more active in that subset of patients. So ibrutinib is a Bruton tyrosine kinase inhibitor that's FDA approved in relapsed CLL. However, several of the RESONATE trials showed that if you had a P53 mutation, which in CLL, we usually do chromosome analysis by FISH, and you can see that the part of the chromosome 17 where P53 lives is absent. And those patients responded remarkably well to ibrutinib and had progression-free and overall survivals of up to 80% at 2 years. And that's remarkable because P53 mutant CLL was a group of patients we previously quickly moved to transplant if we could, because we knew conventional chemotherapy wouldn't work. The one other lymphoid malignancy that I'm going to talk about is hairy cell leukemia. This is a rare lymphoid malignancy. It's a B-cell neoplasm. The reason I talk about it is because it was interesting that in 2011, sequencing of hairy cell leukemia revealed the driver mutation. So this is important because this is actually the mutation that causes the disease. What I've been speaking to you about earlier are mutations that develop in the disease and drive the disease and perhaps confer a worse prognosis. But this is an actual driver. This causes the disease. So this is a mutation in RAF, which is a kinase, meaning it activates and phosphorylates downstream targets in the cell. And sequencing a patient with hairy cell leukemia revealed that there is a substitution that results in one amino acid being replaced by another at a specific site, and that activates all the downstream pathways that come downstream of RAF, which include MEK and ERK, and result in the cells having a very specific transcriptional profile and this hairy-looking appearance where they have these projections. And when you treat them with a RAF inhibitor called bemurafenib, which is already approved in melanoma, that infiltration of the bone marrow with the CD20 positive cells, all the red cells basically go away, the cells revert to normal morphology, and that gene expression profile kind of simmers away and settles down. So this is being tested, and the response rates in relapsed hairy cell leukemia are approaching 100%. That's relevant because while hairy cell leukemia is a rare disease, it is one that relapses several times during its course, and so this may be an important adjunct to use, but is not approved yet in that indication. And finally, my last two slides, I'm just going to talk about how the conventional prognostic scoring systems and some other malignancies have been modified, taking into account molecular findings. So myelofibrosis is a group of diseases called myeloproliferative neoplasms. These are diseases where the bone marrow is consistently switched on and overproducing blood cells. Most of these cells are mature cells and functional, so the patients feel pretty good. However, with myelofibrosis, there can be scarring and eventual burnout of the bone marrow, which leads to bone marrow failure, and there is a mortality pretty significant if you have high-risk disease, and so these patients should be triaged to transplant. So the traditional scoring system is called the DIPSS, or the Dynamic International Prognostic Scoring System, in myelofibrosis, and it incorporated age and blood count, some of which I've put here, and there were weighted scores assigned to each. Anemia was considered a relatively more unfavorable feature. But in 2014, the newest version of that called MIPS, which is the Mutation Enhanced IPSS score, was proposed and studied. And that incorporates the commonly found mutations in myelofibrosis, including JAK2, MPL, and calreticulin. About almost 75 to 85% of patients have one of these mutations, but if you don't have any of them, you're probably going to have a worse outcome. And that's probably because that's a waste paper basket of a lot of driver mutations that we just don't know. But if you're triple negative, that definitely adds quite heavily to your score now. And ASXL is another mutation that has been found to really influence prognosis. So this is relevant because it will change how we approach patients when you evaluate them for transplant. And finally, just touching on MDS. MDS is myelodysplastic syndrome characterized by a bone marrow that is unable to mature blood cells due to a number of acquired genetic abnormalities. MDS is interesting because there are some subtypes of MDS, and you can see a lot of them listed here. Some of these are MDS, and then there's MDS, MP, and overlap syndromes. Sometimes genotype and phenotype correlate really closely. For example, if you have something under the microscope called ring sideroblasts, you almost always have a mutation in a gene called SF3B1. So there's some genotype-phenotype correlation. As you move towards slightly higher risk MDS, you tend to have more mutations than the more low risk MDSs. And it's being recognized that a number of mutations may be relevant. So the more mutations you have, perhaps you have a higher chance of a disease that may be aggressive. And finally, adding the mutation to the traditional prognostic scoring system, which is also called IBSS and MDS, changes your prognosis. And this is just showing for each clinical classification, whether it's low risk, intermediate 1, or intermediate 2, when you add one, so there's a panel of 5 genes that was identified that if you had one of them, it markedly, independently affected your prognosis. So independent of all the clinical factors, if you had one of the 5 genes mutated, which are ASXL, P53, EZH2, RUNX, you would drop down to the next curve. So from low, you'd join the intermediate 1s, you join intermediate 2s, and intermediate 2s would go to unfavorable. So you would drop a notch on the classification system. And my last be the devil's advocate slide is that are we causing a lot of angst when we do this molecular profiling, and is it sometimes unnecessary? And to illustrate that, I have an 82-year-old patient who's in excellent physical health, 5 years out from treatment for breast cancer, for which she got chemotherapy and radiation, but she has this persistent thrombocytopenia where her platelets kind of live around 50,000. Her bone marrow biopsy was not very impressive for any morphologic abnormalities or dysplasia, but mutation testing showed 2 genes that are mutated that are commonly associated with MDS. So what do we do? And so that takes us to this clinical entity known as CHIP, where as we work up patients for cytopenias and this equivocal, do they have MDS, don't they have MDS, they've had chemotherapy, they've had radiation, we're worried about them. And so we look at their mutational profile, and sometimes we find something. It's important to recognize that there were 2 large studies done in thousands of patients, one through WashU and one in Sweden, and these were looking at registries of patients who did not have blood cancers, and up to 10% of patients over age 70 had a mutation in one of these MDS-associated genes. And that probably is just speaking to age-related acquisition of mutations, just an aging system which is accumulating mutations that may never be clinically relevant. So it's just a normal process of aging. The DNA is making mistakes or collecting some mutations, but they're never going to be relevant because these patients did not have blood abnormalities. They did, however, have a slightly increased risk of developing blood cancers, and so it's something to keep in the back of your mind. But to diagnose MDS, we still require a dysplastic morphology, meaning the bone marrow has to look abnormal. The pathologist has to agree that it is MDS. And the blood counts have to be low, and you should be able to demonstrate a clone if possible. And so if our patient basically has a clone of cells, and she's in this category where she's acquired some mutations that have given her a slight clonal advantage, but really requires several additional hits to become MDS or AML. And the rate of developing those additional hits is about 0.1 to 1%. So the majority of patients with CHIP never develop disease. And it's akin to what we think of when we think of myeloma and the pre-myeloma condition called MGUS, where you may have a protein that's abnormal, but the chance of actually becoming full-fledged disease, myeloma, which needs treatment, is 1% per year. So it is surveillance for these patients with the knowledge that they may progress, but odds are they probably won't. And that's it.